We use them for, in many settings, we use them for liver disease. We also use it for remodeling because it's an aldosterone blocker, and patients with severe heart failure with reduced left ventricular ejection fraction benefit from being on this medication. But it has a very important use in hypertension medicine. And when you're thinking about a fourth agent, this is the answer. But you gotta be careful because spironolactone has side effects like every other medication. Which ones are the side effects from spironolactone?
Does it grow a beard or grow facial hair?
No, that's for the Minoxidil, for the vasodilators. Gynecomastia. So gynecomastia. No, it's not dangerous, but it's annoying. So I tell my patients, and I tell them, you know what, you may get this. I mean, if it's bothering you, we can always, it's dose dependent, so you can go down. But I teach them, even female patients, I teach them about nipple sensitivity because they can develop it with this medication, but it's not a contraindication for using it. So make sure you disclose that to your patients. But which one is the most common metabolic electrolyte-wise side effect from spironolactone? Hyperkalemia. So once again, if you're combining an ACE and an ARB, you better let them know, and you better follow the potassium carefully. If you feel your patient is not dependable, your patient has advanced kidney disease. In fact, if you look at the recommendation for usage of spironolactone, they recommend against the use if the GFR is below 60. I use it all the time in my practice because it's very effective, and because I can very easily document and I can refer my patients for formal low potassium education, and I feel very confident that I'm helping my patients. But if for your level, if you're gonna be a primary care doctor, just make sure you can probably, you're the safest if you stick with the GFR greater than 60. If you're gonna make that combination of an ACE spironolactone or ARB spironolactone. So another teaching point for today: do not combine ACE and ARBs. There are some doctors that are still doing that, primarily nephrologists are still doing that, but when I see that tells me that doctor probably hasn't grabbed a book since 2010, because that's when the on-target trial was published, and that's a cardiology study, and that was cardiology. It's in the United States, all over the world, cardiology has a lot of evidence-based practices. And unfortunately, in nephrology, we don't have that many evidence-based practice. So it's more like trial and error, or learning from other specialties, whatever the other specialties do. Whereas cardiology have very, very powerful, randomized, good quality clinical trials guiding the things that they do. And one of them is this trial, which is landmark in hypertension medicine. The on-target trial was basically, it came up with a conclusion is you do not combine ACE ARB because it increases the risk of adverse outcomes, including syncope, hyperkalemia, and progression of kidney disease was one of them. So we do not combine them. Some doctors were doing it for proteinuria control. It does work for proteinuria control, but it doesn't work for the heart outcomes, which is death, survival, bad outcomes like syncope and things like that. So do not combine ACE ARB. If you see that, you need to educate the patient. You need to tell them, like, we're going to try to wean you off one of these meds. Okay? So yeah, spironolactone is great. Make sure you educate your patients. Those are probably the two more common side effects: the nipple sensitivity and gynecomastia, and the hyperkalemia. But make sure you educate your patients. And it should always be the fourth agent when dealing with resistant hypertension. They've done clinical studies actually, and they've looked into like the delta change in blood pressure after adding any drug, any fourth agent versus adding spironolactone, and the delta change is dramatic. Like it's like 12 to 18 points after the addition of spironolactone. And a lot of it has to do with the fact that primary hyperaldo is relatively common. I'm not going to say relatively common, but it's relatively common in those suffering from resistant hypertension. Let's say that I have 100 patients, and let's say that I eliminate pseudo-resistance, and then let's say that we're probably down to 20-something, 20%. Like the chances of any of those 20 patients having primary hyperaldo is actually It's not insignificant. It's about 5 to 10%. So that's why they pimp you on this on your boards. They're gonna give you guarantee. They're gonna give you a clinical scenario where you're gonna have a patient with hypokalemia, metabolic alkalosis, and resistant hypertension. So this is the classic triad for primary hyperaldo. And primary hyperaldo patients, they have an excess of aldosterone. And do you guys know which one is the screening test for primary hyperaldo? You guys remember? Primary hyperaldo, the screening test?
I kind of guess, is it the one where we do the whole aldosterone ADH test where it's you see if it's the brain or if it's the kidney issue, that test?
No, it's the aldosterone, renal aldosterone.
Okay.
So the easy way to remember is R. Aldosterone in the numerator, renin in the denominator. You're never gonna forget it if you remember that. R. Aldosterone in the numerator, renin in the denominator. So that's a screening test. This is a screening test for primary hyperaldosteronism. You're gonna get a question guaranteed on your boards. They're gonna give you that kind of scenario with somebody with resistant hypertension. So the first thing that you do, just to give you everything in a nutshell, is you never order imaging without demonstrating that the patients have a biochemical excess of aldosterone. That's another way that they're gonna try to trick you. They're gonna give you, oh, you already know the triad, so you already know this patient has primary hyperaldo, and they may ask you, what is the next step? And they're gonna tell you, A, order whatever captopril renogram, B, order MRI of the adrenal glands, and then people get excited and they answer imaging. You never order imaging unless you demonstrated that you have biochemical evidence, and the reason being is that I'm pretty sure you've heard about incidentalomas, adrenal incidentalomas. They're quite common. And then you're stuck because you don't know what to do with them. You know, a lot of them are benign. And why did you order in the first place if the patient didn't have an excess of biochemical excess of aldosterone? So the workflow is patient suspected primary hyperaldo. Then you do the screening test, which is the aldosterone over plasma renin activity ratio. If that level is greater than 20, or if the level is greater than 15, the ratio is greater than 15, or the aldosterone is greater than 20, the higher, the more specific, then you're dealing with probable primary hyperaldo. And the next step is confirming that you're dealing with the real deal, which is doing a 24-hour urine assessment for aldosterone. So if your 24-hour urine assessment for aldosterone is greater than 12, then you're dealing with primary hyperaldosteronism. At that point, then you're moved to doing imaging of the adrenal glands, and then it doesn't end there. It's a little complicated, but it doesn't end there. If you actually have evidence of an adrenal mass or adrenal hyperplasia, then before you recommend surgery, you need to do several things. You need to, number one, inquire if the patient is interested in a surgical solution, because this is one of the few things where we can actually fix hypertension with a surgical procedure. But if the patients are very old, they're frail, they have multiple comorbidities, you want to stay away from any type of intervention, and you just manage them with which medication? How do you manage primary hyperaldo? Aldosterone antagonism, right? Spironolactone. And that's the reason why I'm saying that it's so effective, because a lot of times we may be dealing with a primary hyperaldo without knowing it. So that's the first thing you need to do. You need to talk to the patient. You want surgery? If I don't want surgery, why would I bother like doing all this kind of stuff? It is what it is, right? So if they want surgery, you need to demonstrate where this biochemical excess is coming from. So there is a test called adrenal vein sampling, and that's usually done by interventional radiologists. Some urologists actually, they have the skills to do that, but nowadays the urologists are more surgical, more to the point, and interventional radiologists taking over like a lot of these procedures that are not very common, because they can pretty much put a catheter, whatever vein or vessel they want. So you need to actually send simultaneous samples for analysis, and then when you actually have the probable to the likely to the actual imaging showing that this comes from the right adrenal gland, and the adrenal gland is actually showing the excess of the aldosterone, that's the scenario when you actually refer the patient for an adrenalectomy. And then lastly, you need to advise the patients or disclose to the patients that only about 60% of the patients will have a cure in their hypertension, because they may have primary hypertension with a superimposed secondary hypertension. So if you get rid of the secondary hypertension, you may be left with the primary hypertension. So one of my colleagues told me that one of his patients was very upset because after they did all this work, that she's still taking medications. You need to tell them that, because imagine how frustrating it is for a patient having to do all this testing and go to the first place. So that's a little complicated, but for your level of training, the take-home message is suspected with a classic triad, number 1. Never order imaging, number 2. And if the patients don't want surgery, number 3, the drug of choice is spironolactone. So that's all you need to know for your level of training. And don't let them trick you, because they're gonna tell you what is the next step. So the next step is the screening R, and then the confirmatory is the 24-hour urine aldosterone. Okay? Very good. So that's primary hyperaldo. You're gonna get it on your boards, guaranteed. Okay, so going back to medications, I think we cover diuretics. So there is another type of diuretic called the potassium-sparing diuretics. Spironolactone is one of them, but we all know that spironolactone has a very specific site of action, which is in aldosterone receptor. But we also have other potassium-sparing diuretics. Do you guys remember some of them? Remember? Triamterene. So triamterene, it works in the distal collecting tubule, distal collecting duct, and it also increases your potassium. One of the interesting side effects about triamterene is that you can actually form kidney stones, triamterene kidney stones. So I don't think they're going to ask you that question at your level of training. They do ask it in nephrology boards, but that's one of the side effects from this medication, and they're radiolucent stones. Which other potassium diuretics? Potassium sparing? Amiloride. Amiloride is a great medication. If you have a patient with resistant hypertension and that was intolerant to spironolactone, you should try that medicine, because amiloride specifically, there is a mutation called Little syndrome, which is a gain of function mutation of the ENaC, the epithelial sodium channel in the distal collecting duct. And those patients actually, you need to send them for confirmatory testing, which is most of the time is not available, like genetic testing. But if you want to just do a trial and error, I have a patient that I'm convinced she has Little syndrome. I just never really did the testing, because it was involved a lot of paperwork and stuff. I gave her amiloride, and that did it for her. Like incredible control on her blood pressure. So there's another potassium-sparing diuretics. Universally, you need to educate your patients about low potassium diet. So that's why I want to emphasize to you guys, you need to know your foods in high potassium. There's some cultures, I forgot to mention, there's some cultures, especially the Indian and the Nepalese culture. Culturally, they eat a lot of molasses. I don't know if you guys know what molasses are. So they have a lot of potassium. A lot of potassium. It's actually one of the highest potassium contents. So, and seaweed also has a lot of potassium. So seaweed and molasses. So those are two things that you need to educate your patients on. Okay, so all right, so diuretics. So then we have loop diuretics. Loop diuretics really don't have any role in hypertension management. They do have a role in heart failure. They do have a role in volume overload states like cirrhosis, nephrotic syndromes, and congestive heart failure. In nephrology, when the GFR is below 30, we oftentimes switch the thiazide and we switch it for a loop diuretic. Just to try to help a little bit with sodium excretion, but it's really a weak antihypertensive agent. Lasix is a magnificent drug for many other reasons, but in hypertension medicine we stay away from it. All right, and then we cover diuretics, we cover calcium channel blockers, we cover ACE inhibitors, ARBs, and then we have like other things, other medications that I'm particularly not a big fan, but they work. One of them is hydralazine, and I'm not a big fan because we know that compliance is an issue. That was the first thing I told you guys today about compliance. This medication actually, a lot of doctors prescribe it twice a day, but if you really want it to become effective, it's 3 times a day. Have you tried to take a pill 3 times a day? Have you ever taken an antibiotic 3 times a day? Most of the time you forget, or you end up quitting after 7 days. So think about those things, because you have to put your shoes in your patient in your patient's shoes. Is he going to be compliant? If a patient has questionable compliance with follow-up recommendations and things like that, try to stay away from that medicine. But it does work. For your boards, they're gonna want to trick you with the drug-induced lupus. That's one of the most common offenders. So I think there are 3 medications that are more common offendings: the brokinamide, hydralazine, and isoniazid. So just make sure you memorize those, because they may ask you. There is a test called the antihistamine antibody when you suspect about drug-induced lupus. Interestingly, drug-induced lupus can resemble like systemic lupus, but it doesn't really involve the kidneys. But I've had a patient that actually I diagnosed her, came in with severe joint pains, and she's been on hydralazine for a long time, and then it was like a miracle. We stopped that medicine and she felt like $1 million, and she was feeling this way like for years. So it's you see this in clinical practice once in a while. Just remember in the back of your head to suspect it when you have a patient for a long time with this medication. Then we have nitrates. Nitrates are great medications. Cardiologists, they use it all the time. They're safe. They're vasodilators, venous vasodilators. One of the side effects, they're short-acting and long-acting nitrates. You know, the Imdur or isosorbide, that was long-acting, and I think you can start with 30 milligrams. The maximum dose, I believe, is 90 milligrams twice a day. I believe that's the maximum dose. They're very safe medications. Sometimes they can cause headaches, but they're great if you want to kill the 2 birds with the same stone. If you have a patient with angina or coronary disease, those are great medications to prescribe for that purpose. Then we have alpha blockers. They're basically good medications in hypertension medicine. They have a role for males with hypertension when you're looking for an alternative agent, because they can actually improve urinary flow. You know, they have like the same property as Flomex. So we prescribe them. You never start in a higher dose because one of the side effects is orthostatic hypotension, and you have to educate your patients when you're prescribing it, because that's pretty pronounced in the first couple of weeks of therapy. So I usually start them with a very low dose, 1 milligram, and we can titrate, or you can write instructions for the pharmacist to titrate as tolerated. But in the first couple of weeks, the orthostasis can be very symptomatic. The last thing you want is to hear from a patient that, oh, I broke my hip because of that medication. That's actually a nightmare when you have that kind of scenario. So make sure that you cover that. Like, you always give disclosure to your patients. Being effective, you know, I remember one of my med school attendings, I always remember the guy, he told me, like, you want to be a great doctor, you know 20 medications by heart. You know all of it. You know interactions, you know side effects, you know everything, and you're going to be a great doctor. I didn't really quite understand that concept until, you know, you start with clinical practice. If you know them by heart and you make disclosure to your patients, you're likely to achieve the therapeutic goal. And if you don't tell them that these things can happen, they're going to be upset at you. They're going to come like, oh, I don't want this, I don't want that. But, you know, it's a trade-off. No one wants to take medications. I haven't met the first patient that wants to take medications. But it is our job to be able to improve the communication and the understanding of what they're doing, the type of commitment they're getting into. All right, so we have several alpha blockers. We have terazocine, doxazocine, that's also known as Cardura, and we have Hytrin, and what's the other one? Prazocine, Prazocine. They all have this. They all share the same side effect profile, and they're good therapeutic choices when you need to kill 2 birds with 1 stone. But in generally, they can cause severe orthostatic hypotension. Okay, what other medications? Clonidine, right? So clonidine has a role in hypertensive urgencies because it's a short-acting medication, and it works pretty quickly and it wears off very quickly. So when you're dealing with an hypertensive urgency patient, it actually works very well. When you see a patient coming in with clonidine, it's because they already exhausted other options. And in my practice, when they come, you know, I'm board certified in clinical hypertension, so I get a lot of referrals of hypertension, complex hypertension cases, and a lot of the times they come in and they have a list this long of intolerances and allergies, and I start talking to the patient. So tell me what happened with this. No, I have edema. That's not an allergy, right? So we learned that today, guys. Like, our job is, so then that's why you come in here with with Minoxidil and alpha-methyl-dopa and all these dinosaur medications that they should have never started in the first place. So that's why communication, everything is about going with the patient. So clonidine is a great medication for that purpose. However, I have a problem with clonidine, and which is two things. Number one, the rebound hypertension. If you're not compliant with it, if you have questionable compliance, don't prescribe it. When you prescribe it, you need to understand, the patient needs to understand that they cannot skip it. It's dangerous. If they skip it, they can have a hypertensive emergency. So they need to know that. That's number one. For that reason, actually, the patch is actually superior to the pill, because the patch can actually confer like good 24-hour control versus the pill, where if you miss the afternoon dose, is a Q8. If you miss the Q8 or the Q12, depending on how the regimen is, then your patient is going to have these unhealthy spikes in their blood pressures. So that's number one. Number two, in combination with beta blockers, you know what happens?
Well, so we know that clonidine has terrible parasympathetic side effects. Now with the beta blocker, with that, I'm trying to think.
They actually augmented AB nodal blockade. So yeah, so patients can become like symptomatic bradycardia, they can end up with syncope, they can end up with a pacemaker, or they can even die. So you're gonna see that in clinical practice. I personally stay away from that combination. So there's three combinations that I want you guys to walk away from this talk. One is ACE and ARBs. I already explained the reasons. Second one is clonidine and beta blockers. So can you do it? Yes, you can do it, but you need to be supervising the patient's heart rate, and you need to be aware of it and disclose it to the patients. And another combination that is doable, but you need to know what you're doing, like Dr. Ben-Zur does. Like he prescribes calcium channel blockers with like diltiazem and verapamil. He prescribes with beta blockers. Why? Because he does a lot of management of complex EP electrophysiology disturbances, and he knows what he's doing. But if you guys are going into primary care and you don't know about these interactions, and you prescribe, I got a patient once on clonidine, diltiazem, and a calcium channel blocker, and clonidine, beta blocker, and diltiazem. The guy's heart rate in my office was 37. So I didn't tell him anything, because the last thing I want is to have a patient go after a colleague of mine. But just make sure that you guys know what you're doing. If you make those combinations, that's just not good. You need to know, at least you need to know what are the possible side effects of doing that combination. So just make sure that doesn't get you by surprise. Another thing that I always teach to students is the fact that if you have a transplant patient, and the transplant patient, whatever organ, either a kidney or a liver, whatever, a heart, sometimes now we're seeing patients with like gut, small intestine, pancreas. You're going to see more and more transplant medicine is becoming like pretty much, if you're going into primary care, you need to be very familiar with transplant medicine. I can give you guys a talk about transplant, but anyway. So if you have a transplant patient coming in with either verapamil or diltiazem, do not touch that medication. It's actually a transplant medicine. And the way it works is that we take advantage of the cytochrome P450 interaction. When I prescribe a calcineurin inhibitor and a calcium channel blocker, actually I'm saving money, because the patients are getting therapeutic level with less doses of cyclosporin or tacrolimus. If you stop that medication because, oh, this is a weak blood pressure medicine, or let me give you this one, is better, you own that transplant at that time. Because the next thing is going to happen is that the level is going to be under therapeutic, and that organ is going to reject. So always remember that. I don't want you guys to change. And if you have a transplant patient, the best thing you can do is just send a note to a transplant doctor. Because they have transplant, every patient with an organ, they have a transplant hepatologist, a transplant cardiologist, or a transplant, nephrologist. Okay? So basically those are the three bad combinations that I recommend that you guys stay away from. And then we have other medications like Minoxidil is a great medication in terms of blood pressure reduction. It's a terrible choice when it comes down to advanced kidney disease, because that causes renal sodium retention and causes a lot of edema. And I don't use it, because when I was in training, like you guys, when I was in med school, I saw a person dying from a pericardial tamponade, from a pericardial effusion from Minoxidil. So that's one of the rare serious side effects from Minoxidil. So if you guys can like it comes down to the same talk that I've told you for the last hour. If you can use first-line agents, just teach your patients this is tolerable versus not tolerable versus these are like a worse side effect profile. And then we have other antihypertensive medicines that probably no longer in use, Reserpine, centrally acting blood pressure medicines. We have alpha-methyldopa. Some OB/GYN doctors, they still use it. It's a very ineffective medication. I've never prescribed that medication. I took care of a patient once that was on it from the OB doctor, but there are other medications that we can use in pregnancy, like including calcium channel blockers, hydralazine, that are more effective than alpha-methyldopa. But anyway, that's basically in a nutshell hypertension meds. That's basically in a nutshell pseudo-resistant and resistant hypertension. They may ask you about zebras, hypertension zebras in your boards, and probably the most common one, I've only seen 2 cases in my whole career of pheochromocytoma, but for whatever reason they love to ask that question on your boards, so you need to know about pheo. I'm going to comment on pheo. So pheo is actually it's a tumor that is most likely originating from the adrenal glands, but you can have extra adrenal pheochromocytomas. The tumor itself has a very unique radiographic appearance, and if a radiologist is calling it a pheo, you better believe it. And I'm saying this because there is a pre-biochemical phase. In other words, you can have the mass forming, but you don't have the biochemical excess. Don't ignore it, because that patient needs to be closely supervised. In other words, you need to measure fractionated catecholamines, fractionated serum catecholamines, and some of the urine studies I'll tell you in a minute, because in the future they may develop the real syndrome. And I'm saying radiographic appearance because it's a very irregular shaped cystic mass that radiologists are very familiar, to call it pheo. Pheo, the classic board question, they're going to give you a lady because it's more commonly seen in females. She's having paroxysmal hypertension, she's having orthostatic hypotension, she's having flushing, she's having palpitations, and she's having like pretty severe hypertensive crisis. Or they may also give you another vignette, another clinical scenario where the patient is actually getting general anesthesia and they go crazy. They have a hypertensive crisis. So you think about pheo when you're given that clinical scenario. There are the screening tests. The test of choice is fractionated serum metanephrines, but you can also order the 24-hour urine studies. If it's mildly positive, don't get too excited, because the textbook definition is to be able to call it pheo, you need to have 3 to 5 times the upper level of normal. So if you get a little abnormal, don't get too excited. And the reason being is there are many medications that can give you a false positive screening for pheo, including stuff that you buy over the counter, like if you get a cold and you buy like Sudafed, that stuff can give you a false positive test for pheo. Or even TCAs, tricyclic antidepressants, can give you a false positive test for pheo. So the management is a surgical disease. So it's one of those other few things, and I'm saying I've seen 2 cases, and one of them was my colleague, my nephrology colleague. We were doing the transplant rotation and she self-diagnosed with pheo. She was having headaches, she was having like severe hypertension, and she was like, what is wrong with me? This is so weird. And she ordered the testing and she ended up having pheo, and she ended up like basically Will had to cover her rotation. It wasn't fun, but it was. I was glad that it was actually awesome that she was able to diagnose herself. It's a story forever. But anyway, so and it's very rare. But on your boards, they're gonna ask you. The other clinical scenario where you're gonna be asked about pheo is when they give you the MEN1 and the MEN2 syndrome. Every time I study that, I forget it the next day. So my advice to you is make sure you grab a book, you look at that picture the day before the test, and make sure you memorize. I think MEN1 is associated with gastric, parathyroid, and pheo.
The 3 Ps.
Right. Yeah, so I always confuse them. But my advice to you guys is make sure you review that before you take your boards. Okay? So what other zebras in hypertension? We have like other stuff, like you guys don't need to know this for your level of training. We have apparent mineralocorticoid excess syndromes. We have glucocorticoid remediable hypertension. We have Gordon syndrome. We have Little syndrome. You know, like a lot of little zebras that you don't need to know this for your level of training. I think it's more important that you concentrate on medication side effect profile. And primary hyperaldo is huge. Theo is huge. Renovascular hypertension, they also ask you questions about renovascular hypertension. So who do you suspect? So number one, how many types of renovascular hypertension you guys remember? They may give you a clinical case where they show you like a young female with severe hypertension. Then you think about what condition?
Like some sort of
Fibromuscular dysplasia of the renal arteries. So those patients actually, the difference, there's two types of renovascular hypertension. One is from fibromuscular dysplasia, usually in females. It's like a type of a congenital thing, but you can also develop fibromuscular dysplasia if you, for whatever reason, you had trauma to your abdomen or you were exposed to radiation therapy. Those patients can actually develop it. And the difference between that and the other type, which is called atherosclerotic renal artery stenosis, is that the fibromuscular dysplasia is usually like in the mid or in the distal segment of the renal artery. So if they show you a picture of the renal angiogram, you're gonna see that the obstruction, number one, they're gonna give you a young person or with a history like what I just mentioned. And number two, they're gonna show you that the blockage is at the mid level or at the distal level. So those two things. Whereas the atherosclerotic renal artery stenosis patient, it's almost always a disease from old people or somebody with accelerated atherosclerosis for whatever reason. You have severe hyperlipidemia or familial hyperlipidemia or nephrotic syndrome. But these patients actually have, just imagine, like the way you should memorize it is just imagine like a lot of plaque in the aorta going into the renal arteries. So these patients actually have, the plaque formation is mostly in the proximal third of the renal arteries. If you remember that, the aorta and then the proximal third, you're not going to confuse them. So these patients, they almost always have other types of blockages. Either they have coronary disease, status post CABG, or they have CVAs, status post, strokes, or they have PVD, severe peripheral vascular disease. So, and that's what I'm saying, like having this type of involvement is not just uniquely to the renal arteries. It's almost guaranteed you're going to have extensive disease in other places. So the way we manage, like unlike what they teach you in medical school, is you use ACE inhibitors for these patients. You just have to be more careful the way you prescribe and the way you monitor the renal function. It's a renin-dependent disease. You wanna blockade renin to be able to help these patients, and we treat them with aggressive lipid goals, and we treat them with antiplatelet therapy. Either an aspirin or Plavix should be part of the regimen on these patients. The prognosis is not very good because, like I said, guys, it's not just involving the kidneys, it's involving other vital organs. And patients with severe atherosclerotic renal artery stenosis, they almost invariably end up having trouble from the heart or the brain perspective. Before we used to, in some selected cases, we still take patients to the OR to do stents, but they've done clinical studies and we don't necessarily do it in everyone anymore. Why? Because we have very good antihypertensive medicines and they've done head-to-head comparisons from medical treatment versus intervention. And the most recent trial is called the CORAL trial, and that was published a couple of years ago in the New England Journal. And the outcomes are no different. In fact, the procedure arm, it carried like more risk for other things. But having said that, we still do some of these procedures in some selected patients, especially those patients with severe hypertension that you guys can get them under control and they still have somewhat preserved renal function. Those patients may benefit from stenting them. But again, you're not going to be asked that question. But renal vascular hypertension is going to be on your boards for sure. Okay, so let me think about what other causes of secondary hypertension. We covered sleep apnea briefly. The way I think about it is like, just think about a body, human body, and then differential for secondary hypertension. So you can have CNS occupying lesions. Those ones cause severe hypertension. Or you can have pseudo pheochromocytoma. We talk about it, like those patients get anxious, or they have like some sort of like anxiety background, and actually they improve when you prescribe an SSRI. And you need to have a very open conversation, and it's a diagnosis of exclusion. In other words, you can't tell a lady, hey, you have pseudo pheochromocytoma, you need to see a psychiatrist. You're going to be like, see ya, I'm going to go to another doctor. To have good rapport with the patient, you need to explain the options, the workup, and it's a diagnosis of exclusion. So going back to the neck, we have sleep apnea. It's responsible. Secondary hyperparathyroidism, either primary, secondary, or tertiary hyperparathyroidism, can be associated with resistant hypertension or severe hypertension. So part of the workup with these patients is we check a PTH for these patients. So you guys remember the difference between primary, secondary, and tertiary, more or less? So primary is like adenoma. It's just secreting excessive PTH. These patients usually they have low phosphorus because it's a phosphaturic hormone, and borderline high or even high calcium. Patients with primary on your boards, primary hyperparathyroidism, they can present with kidney stones, or they can present with osteoporosis, early onset osteoporosis. So they may give you that kind of a scenario, and you know that you're dealing with primary hyperparathyroidism.
That's a question. What is the mechanism behind hyperparathyroid hormone causing hypertension?
Excellent question. You know, it's not fully elucidated. We know from extensive research that having a lot of PTH is associated with hardening of the arteries, and actually with premature with cardiovascular complication. And that's why if you end up rotating a dialysis unit, you're going to see that we pay a lot of attention keeping the PTH within some therapeutic ranges. And it's not fully understood, but like a lot of PTH causes a lot of hardening of the arteries. And that's what we know so far from evidence. In the neck, we also have both hypo and hyperthyroidism that can be associated with secondary hypertension. So you screen for both. Simple test, you do a TSH. If you want to be thorough, you do TSH, T3, T4. And the reason being is that if you have central hypothyroidism, TSH is useless. You need to check the full panel, the T3, T4. Okay, going to the heart and the chest, we have coarctation of the aorta. On your boards, they may give you like a Turner syndrome. You know, in those patients, you know, you're able to tell by checking blood pressure in the upper and in the lower extremities. There is a discrepancy on the blood pressure measurements, but like you can also make the diagnosis with a chest CT or even an echocardiogram. You can see the findings consistent with coarctation. These patients usually tend to be younger, and if you live for many years with unidentified aortic coarctation, you're very lucky, because you know these patients they have severe complications from that. All right, just moving to the kidneys. We talked about renal artery stenosis, and the way I teach the students, the most common cause in kidney disease is so common to have hypertension that it comes to the point like, what was first, the chicken or the egg? And the reason is very simple. If you think about it, like I told you this when we started talking today, if you have an impaired ability to excrete sodium, you're going to have hypertension, period. There's so much sodium excretion that you can accomplish if you have a limited nephrons. And you guys know from physiology that if you already have a GFR of 40%, that's pretty severe. That means that you lost probably like 80% or 70% of your kidney tissue. So that's why kidney disease, they call it like secondary hypertension. Is not really secondary hypertension, it's your inability to get rid of the sodium. So there are some types of primary kidney disease that are associated with severe hypertension, and you probably learned this during your pediatric reviews. Some of the GNs, like nephritic syndromes, like that's one of the characteristics. They present with severe hypertension. I'm talking about patients with crescentic GNs, like either they have an RPGN from IgA nephropathy or from post-strep glomerulonephritis, or like the RPGNs, the nephritic. We can talk about it like some other day, the difference between nephritic and nephrotic. But these patients, one of the characteristics is that they present with severe hypertension. But when we're talking about horses, we're not talking about zebras. When we talk about horses, is your inability to excrete sodium. For those suffering from these primary GNs, those are zebras. And then we do see severe hypertension in those patients. And then we have, in the adrenal glands, we talk about primary hyperaldo, we talk about some of these genetic syndromes that you don't need to know much about. And then we talk about pheochromocytoma. And then you can also be dealing with paraneoplastic syndromes. You know, sometimes one of the presentations of a paraneoplastic syndrome can be severe hypertension from excess of catecholamines or some other hormone, adrenaline, some other form of hypertension. Yeah, I think that's pretty much it when it comes down to differential, primary medications, treatment. What else can I tell you guys? Oh, diagnosis. So let me just tell you, this is important that you need to know this. So we're moving more and more, and I've been telling Dr. Ben-Zur about the role of the 24-hour ambulatory blood pressure monitoring. We're moving more and more into making the diagnosis either with home readings or the 24-hour ambulatory blood pressure monitoring. Have you heard about the 24-hour AMBP? No? Okay.
Is it just the box that they go home with? The home monitor?
Right. It's like,
okay.
Think about like a Holter monitor, but instead of that, it's like a cuff with a blood pressure machine, basically measuring your blood pressure every 30 minutes when you're awake, and you can set it up to do it every 30 or every 60 minutes when you're asleep. So the 24-hour ambulatory blood pressure monitoring serves several purposes. It serves a diagnostic purpose to diagnose white coat hypertension, so very common. So you can average, if your blood pressure is greater than 135 or 85 in a 24-hour period, then you call it hypertension. If it's less than that, then you can say this person, you can confidently say this person has white coat hypertension. So that's one purpose that it serves. Another purpose is it can diagnose masked hypertension. Those patients that are coming to the office and they have normal readings, yet at home they're having findings consistent with hypertension. And there is a prognostic role that it serves. And I'm sure you've heard about the nocturnal dip in the blood pressure pattern. Have you guys heard about that? So physiologically, we all go through a dipping process. When we fall asleep, the dipping can be anywhere from 10 to 20 or even more when we sleep. Systolic blood pressure can dip or will dip. If you have a non-dipping pattern, that confers a higher risk category for those patients suffering from hypertension. And we know that those patients, they probably need more strict, more aggressive goals. And we also, from that information, we can also deduct that your patient may have unrecognized sleep apnea, because that's one of the pattern of the non-dippers. The non-dippers, they may have like apneic episodes that are contributing with the hypertension. And we learned today that the impact in managing the sleep apnea is not pretty powerful, bringing down blood pressure, but the consequences of untreated sleep apnea, they're pretty severe. So the take-home message is that we do, when we diagnose sleep apnea, we need to treat it. Okay? So yeah, so ambulatory blood pressure monitoring is becoming more and more recognized as the gold standard for hypertension, for the diagnosis of hypertension. It's a test that it's a little inconvenient for the patient, but it gives good information. We always tell the patient to monitor because they're more reliable, but sometimes the patients are not using the proper technique, they don't have a reliable instrument. All sorts of things can happen at home, whereas if you have a calibrated instrument, a 24-hour instrument, you can very accurately diagnose and treat your patients with that. Okay. So let me think, what else? Any questions? I mean, I'm trying to think what else in terms of hypertension.
You have a Google Doc with some questions, but I think you covered a lot of our questions,
Yeah,
right?
you really did. Yeah.
Yeah, I mean, no, you guys can call me or email me, but in general, like what I want you guys to take home message is like do your homework. Don't just prescribe Prescribing is for pharmacists or for PAs, or I'm sorry, but I mean, I don't mean to be disrespectful for their profession, PAs and nurse practitioners, but you guys as physicians, you guys need to understand your role. And your role is to be able to recognize patterns of disease and think outside of the box. And a lot of these healthcare professionals, they're excellent taking care of like the straightforward things, but you as doctors, you need to think outside the box. And to be able to think outside the box, you need to be able to recognize patterns, think about zebras, think about pseudo-resistance, and be thorough. You guys are here in med school for a reason. You're not here, you're not here because of chance or luck. You're here because you're detail-oriented people, and we have to be detail-oriented. In this business, it's a tough business. You can harm people if you don't pay attention, but if you know what you're doing and your prescribing practices are good, communication is good, just be confident. You guys are going to be just fine. But your job is to, like when you're working here at the Cardiovascular Institute, is get a good history. One very important thing that nobody teaches you, like Dr. Ben-Zur taught me this, but nobody teaches you this in medical school, in life, is your ability to create a patient-physician relationship, your ability to be an effective communicator. That's going to take you to very, 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 very important levels in life. If you're unable to communicate, and when it comes down to interviewing in a program, interviewing for a job, or even having a successful practice like Dr. Ben-Zur does, it comes down to your ability to communicate with your patients, to improve their care experience, to know that you're making a difference. And you don't have to be textbook smart, you just have to be people skills smart. So when you go there and you are able to talk to someone, enjoy that interaction. Like, that's how I see it. Like, we have a job that we're privileged to have a job, like we're able to listen to people, to have the ability to help them in every possible way. Sometimes my patients tell me things that I know I can't do anything, but to me it's a privilege that they're actually telling me about their own sufferings or their own concerns or things that are totally unrelated to medicine. But I enjoy every interaction, and when I was here, I was able to develop very strong ties with the patients. I want you guys to do that, like to listen to some of these people. I don't know how long you've been here, but some of the people that come see him, they're very important people. They're very successful business people. They're very successful, even professors. Like, he takes care of people that are very like top of the top, and he also takes care of people that are, like I was just telling you initially, they probably have no educational background. Like, some of my patients, they don't even know how to read and write. So your job as a doctor is to have the ability to have very positive interactions from this top executive to this person who actually has no education, because your commitment is to help that individual. And I learned a lot of this stuff with him,